Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of a young guy who presented with complaints of fever and sore throat. So there was this 22-year-old male who presented to us with his complaints of fever, abdominal discomfort and sore throat since about 4 to 5 days. In our initial 10-second assessment, patient was conscious-oriented, obeying commands. Primary survey was also uneventful with airway being patent. He was able to speak in one full sentence, no hoarseness of voice seen, no excessive pooling of secretions noted, no anatomical deformities, and no change in the voice also. And then breathing wise, he was having a normal respiratory rate of 17 cycles per minute, maintaining saturation of 99% in room air. Air entry to be bilaterally equal with no added sounds heard on auscultation. Circulation wise, he had a respiratory rate, heart rate of 96 beats per minute with a blood pressure of 120/80. All peripheral pulses were palpable. Disability-wise, he had a full GCS score and pupils were also bilaterally symmetrically and reactive to light. Exposure-wise, he was febrile with a body temperature of 99.8 degree Fahrenheit with normal blood sugar levels of 106 milligram per deciliter.
Okay.
So, since there was nothing acute, adjuncts to pyroxene was nothing, nothing was done.
Okay. Basically, we have a young male who has come with fever and
sore throat.
That's it. Okay, so it's when you call it as a triage category, he'll be in the green category. He has come to the emergency room with the history of fever and sore throat. So it's one of the most common presentation these days that we are getting. Fever with sore throat. Most probably this viral infections they are coming up. Okay.
So in our sample history, we noticed that the patient does not have any comorbidity. There is no drug allergy, medication history, surgical history is in there. But his event that led to this condition is that the patient first had low-grade fever, following which he developed throat irritation and then difficulty to swallow. Odynophagia was there to a mild degree. Along with this, he had abdominal discomfort with 1 or 2 episodes of loose stools. Nausea was there, and then when he was evaluated to local hospital, he was found to have lymphadenopathy. Cervical and posterior auricular lymphadenopathy was present, and because his symptoms persisted is why he visited to our hospital. So in our general physical examination, patient was moderately built, nourished, no pallor icterus, but lymphadenopathy was positive. Like patient had posterior cervical and auricular lymph nodes were palpable, symmetrical on both the sides of the neck, and no other lymph nodes were palpable. So only the cervical lymph nodes were positive. Then other physical examination, systemic examination was unremarkable. And so with this, we went ahead with blood investigations, wherein we took a basic CBC CRP.
Okay, just wait. General physical examination you said. Can you just tell about the examination findings, throat examination findings, before you go for the blood?
ENT examinations, eyes, nose were normal, unremarkable. Oral cavity, patient had pharyngitis, pharyngeal inflammation was there. Tonsils were normal. Then no excessive pooling of secretions seen. And
sinus tenderness?
Sinus tendernesses were in there.
Was in there. Okay.
Non-tender sinuses. And halitosis, dental caries, nothing of that.
Nothing was there. Okay. So note, just a pharyngeal inflammation was noted. Tonsils were of normal size. Okay. Then what else? Chest examination, anything positive?
Chest examination, unremarkable.
Abdominal examination?
Abdominal examination, it was grossly unremarkable, but we had a strong suspicion of the patient having a hepatosplenomegaly, but it wasn't, we couldn't say for certain. Okay. So we did an ultrasound scan and patient was shown to have hepatosplenomegaly.
So basically we have a young male who has come with fever, sore throat, and outside he got evaluated where he has found to have cervical lymphadenopathy, anterior as well as posterior auricular cervical lymphadenopathy, and clinically he had just some no major issues except for a pharyngeal inflammation and for hepatosplenomegaly in the ultrasound.
And lymphadenopathy.
So lymphadenopathy, now you can just describe regarding lymphadenopathy, whether it was matted or it was single lymph nodes, How was the feel of the lymph nodes, everything? You can just describe it again.
So lymph nodes were matted and symmetrical on both the sides,
Mm.
and only the posterior cervical and posterior auricular were palpable. Digastric, then the supraclavicular lymph nodes, axillary lymph nodes, inguinal lymph nodes were not.
So he never had any generalized lymphadenopathy. He only had a cervical lymphadenopathy. What is the most common cause for a cervical lymphadenopathy?
TB in India, cold TB.
What's the most common cause? Most common cause.
Viral infections.
You can tell that most common cause for posterior cervical, especially, is dandruff. That is one of the most common reason for posterior cervical lymphadenopathy. Dandruff is one of the most common reason that you will see. The next thing, it can have a small dental caries. So dental caries, tonsillitis, all those things will have anterior, mononuclear digastric, as you mentioned. But one of the most common is dandruff. But if it is not resolving after a long time and it is increasing in size, then you have to consider tuberculosis as one of the most important differential diagnosis. And any of the viral infections, they can present with cervical lymphadenopathy also.
So fever with lymphadenopathy are these since he's young, could be a infectious mononucleosis, could be brucellosis, a cat scratch disease can be there, or any viral infection.
Any high risk behavior for this patient you noticed? Can really call it as a high risk behavior, but IMN, and it's more common to have when you have the classical history will be, it's otherwise called as a kissing disease. So that part you can ask for any history. Any of his partner has got this similar episode, so it will more in pronounce towards an IMN. And what else other history that you can get for IMN?
One would be sexual history, sir, and the second part would be any in the family, if anybody has it, it is basically
the most other one. It is not a good history, but still the most important thing is, this general practitioners, when they see this patient with lymphadenopathy, throat pain, fever, they might prescribe penicillins. So if they take penicillin, they can come with rashes. So that is very common with IMN. So when you are seeing fever with lymphadenopathy, in a general OP practice, you should not start them on penicillins like augmentin, amoxicillin. If they take these drugs, they can come up with rash. That can be taken as a diagnostic criteria for IMN, but it is very common to have an IMN to have a rash following intake of amoxicillin. So that history you can ask. Usually they will go to hospital. If they have prescribed him penicillin and after that he developed rashes, it is classical of IMN. That is one history that you can get from him. Okay. So you said IMN as one of the differential diagnoses. So how long this has been there for him now? Cervical lymph nodes?
That's been about a week. Sir.
About a week. What will be the usual cause for an viral lymphadenopathy?
So in infectious mononucleosis, it will peak in a span of about a week. Then after a week, towards the end of a week to second or third week, it will start to subside.
Okay. So usually it is a self-limiting disease. You just leave it alone within 2 to 3 days. Maybe some anti-inflammatory for the pain, some analgesics should be sufficient enough for the patient. It's a self-limiting disease. No need of any antibiotics or anything. It is a self-limiting disease, and by the time it will, after 2 weeks, it will get subsided by itself. Okay. Now you said regarding IMN as one of your differential diagnoses. What will be your second one?
CMV, because clinically it will not be very different. So
okay.
Herpes.
Any viral infections you can keep it, and in most common is IMN. To commonly have fever, hepatosplenomegaly with lymphadenopathy, we have to think of IMN as the first differential diagnosis. Then
Group A streptococcal infections.
Group A streptococcal infection. So how will you confirm that?
You'll send that test IgC.
One thing is that you can take a swab. You can take a swab if there is any inflamed tonsils or anything, but you are not seeing any inflamed tonsil. Other one is one isotype will help you to have a conclusion that probably this patient had a group A streptococcal infection. That is the only thing that you can have it. Then
brucellosis can present.
Brucellosis, again, classical history, you will be uncooked, dairy milk which is not properly cooked and all, they can have. Then
cat scratch disease can present, or malignancies like leukemia, lymphomas.
What is Kikuchi's disease?
Kikuchi is again a miscellaneous.
So Kikuchi's disease is again one of the most common presentation like this. The patient will be visiting to your hospital with this fever and lymphadenopathy for maybe 4 to 6 weeks. 4 to 6 weeks, and it is basically an histiocytic necrotizing lymphadenitis. It is again a self-limiting disease. If you give like 4 to 6 weeks of time, it will subside by itself. But Kikuchi has got very much similarity with tuberculosis. So we are very concerned, the patient will be very much concerned whether it is tuberculosis or whether it is malignancy or Kikuchi. So Kikuchi disease is one of the, especially in females, they will come very frequently with similar, so they started having a fever, but lymphadenopathy is not going. Whenever you examine, the lymph nodes are still there. When you do an ultrasound also, lymph nodes are there. They are very much concerned. So we are in a doubt whether to go ahead with a biopsy or not. So even like the classical dictum is that if after 2 weeks, if the lymph node have not subsided in size, you have to have a pathological diagnosis. Either an FNA, ideally will be an excision biopsy if it is significantly enlarged in size. So at that time you will be having, it will giving a history of again necrotizing lymphadenitis. Again it can be part of your tuberculosis also. So again whether to start ATT will be a lot of concerns for us. So Kikuchi's disease is a very common thing, even if it is said in the literature that it is uncommon. So very commonly when we see these patients with lymphadenopathy, we have to keep one differential diagnosis as Kikuchi's disease. So that is one thing that you can consider, and tuberculosis. But this is a very short history, and hepatosplenomegaly all pointing towards an IML. So our general idea, suppose a patient not in ED, anywhere with fever with lymphadenopathy, you can do the general markers and you can give symptomatic management. Only if you are very pretty sure, if needed an antibiotic, you can give a non-penicillin antibiotic like azithromycin. You want to, or doxycycline, which has got very good coverage if you think in terms of a bacterial infection. Otherwise, just a symptomatic management will be more than enough. And almost all these things, except for tuberculosis and malignancy, it's a self-limiting disease. It will subside by itself. Maybe after within 2 to 3 weeks, it will subside. And just you need to do a follow-up with an ultrasound nick. That should be more than enough. So continue, can.
So this patient was, when we sent it blood investigations, he had a lymphocytic predominant blood picture, even on peripheral blood smear, wherein he was found to have atypical lymphocytosis. And then along with this, he also was noted to have deranged LFT. So deranged LFT with fever, lymphadenopathy again points towards infectious mononucleosis. And then otherwise his other RFT and other...
all parameters were normal.
Yeah, unremarkable.
Peripheral smear just showed some
atypical lymphocytosis, but platelets and
everything
RBCs
was
were
normal.
So with this, and like I mentioned earlier, ultrasound of the abdomen showed
hepatosplenomegaly.
And patient was examined for any rashes, and he did not seem to have any rashes as such. So we sent for investigations with a strong suspicion, and patient turned out to be positive for EBV IgM.
Epstein-Barr virus, really it is not needed. So really it is not that why we have sent for this is because the patient and bystanders are very much concerned why is he having this. So ideally Epstein-Barr virus infection is a self-limiting disease. So after 2 to 3 weeks it will subside by itself. But since the patient bystander were concerned, we had sent an EBV IgM, which was a previous test which was used to done when we
heterophile antibody, the monospot test.
Paul Bonnell test. It was the previous one whenever we studied. That was the test described. Now we have got a EBV IgM, which again after 1 week of infection, if you send that IgM become positive, it's a very common thing. So the key messages that you need to remember is that any patient that is coming to you with fever, throat pain, and lymphadenopathy, don't start them on penicillin. So with a short history, it can be an IMN. If you are not very sure there is no lymphadenopathy, you are pretty sure it's a bacterial tonsillitis, that you are having a pus pointing, everything, then there is no harm. Otherwise, generalized just fever, mild throat pain, and when you examine there is lymphadenopathy, when you start with penicillin, they will come up with a rash for sure. So we can avoid that. Instead of, we can start either on an azithromycin, which is again a very good anti-inflammatory agent as such, and it will have got good Campbell's coverage also, and maybe doxycycline if needed you can start. The only thing is that you need to have a follow-up for this patient. After 2 weeks, for example, this patient, it was positive, we are happy, okay, we have got a diagnosis. But otherwise, if the lymphadenopathy is not subsiding after 2 to 3 weeks of your treatment, the size has not decreased in size, then you need to definitely go ahead with the histopathological examination, either an FNAC or an excision biopsy. And as I told, there are a lot of differential that you need to consider, whether it's just a starting of a tuberculous lymphadenitis or a Kikuchi's disease, which are the very common together disease that we can have, and very rarely lymphoma, because he only has got a cervical lymphadenopathy. If it's a generalized lymphadenopathy, more in favor of a lymphoma also we need to consider.
Then and the other treatment modalities, steroids is again a very controversial,
Role.
has a very controversial role to play. And then there are trials on acyclovir also being tried, but so far studies have not shown any benefit in usage of acyclovir.
Yes.
And at present there are no vaccines to prevent infectious mononucleosis. Again, it's under trial.
Right.
Then these patients will have a long-term fatigue, which has to be informed to them, and there will be carriers of EBV virus for a long time. Like they will start shedding it in their oropharynx saliva.
Just like any other viral infection, after that initial prodrome phase, and after that it will be infective phase. So they will be infective like in another 3 to 4 weeks. So that time they will be infected. So they should have a proper barrier methods that they should follow, especially when having this is otherwise called as a kissing disease. So sexual contact, all these advices you need to give to the patient. Okay. So in a nutshell, you have a patient with fever with lymphadenopathy, and examination didn't reveal any major finding except for a pharyngitis. And when you examined with an ultrasound, you got a hepatosplenomegaly. In CBC, there was a predominant lymphocytic predominant total count increase, and he never had deranged LFT was also there. And later on, EBV virus turned out to be positive. So fever, lymphadenopathy, differentials we have discussed. What are the common? IMN, one of the most common infectious diseases. Any other viral infection also can come similarly. How to differentiate between tuberculosis and other common differentials we have discussed. Okay, thank you.